Okay. Can everybody hear me okay? All right. Thanks everybody for coming. Thank you to dvm360 for having me here, and to Zomedica for sponsoring this talk. It's really an honor. So my name is Dr. Shadia Rafij. I'm a board-certified surgeon, and we're going to talk about brachycephalic airway syndrome. I do recognize that a lot of folks here probably have extensive experience on this, regardless of whether or not you're a specialist. Feel free to chime in or give me any experiences you have that are different than what I'm talking about here. And if you have access to the proceedings, they are very, very detailed, way more detailed than we're going to go into at this talk. I aim to make this more of a clinical application, things you can use in your day-to-day life and practice. So just a little bit about me. I graduated from Cornell University in 2006. After that, yeah, Cornell? After that, Angel Animal Medical Center for my one-year general internship. And then from there, I went on the path of specializing in surgery. So I did two one-year surgical internships at Long Island Veterinary Specialist, the 3-year residency at Long Island Veterinary Specialist as well, and was staff surgeon there for a bit, and then moved from New York, went out west Las Vegas, worked at a specialty hospital there for about 9 months. After that, I traveled the country performing surgeries, giving their surgeon a break, and then became the surgeon at United in Silicon Valley, where I managed 3 hospitals. So I was on call 24/7 at that point for 3 locations as the only surgeon. And then I became part owner of a hospital in Studio City, True Care for Pets. After that, I launched Vet Triage, the virtual platform, which I'm happy to talk about if anyone's interested afterwards as well. So we're going to go into a variety of different topics regarding brachycephalic airway syndrome. And again, we're going to keep it as clinical as possible with these. But we're going to define it, talk about the pathophysiology, the related GI disease with these dogs, of course, how to work them up, management, monitoring, complications, prognosis, and then, of course, any questions you have, I'm happy to entertain. The condition, of course, like many conditions in our field, is multifactorial and complex. So this is just a short list of the abnormalities you can find with these dogs. As you investigate further in the literature and you perform high advanced imaging on these dogs, you'll find many congenital issues that they have, which is not surprising to anybody here. Brachycephalics are not, they're known for having many different abnormalities to them, to that breed. So the elongated soft palate, hypoplastic trachea, nasopharyngeal stenosis, stenotic nares, everted saccules, everted tonsils, and laryngeal collapse are just some of the abnormalities that we see. You don't have to have all of these abnormalities in a single brachycephalic dog. The literature does break it down into what the most common abnormalities are in conjunction with each other. And so most of the time you're looking for the nares, the palate, and the everted saccules. That's the most common combination of conditions we see with this syndrome. But there are a variety of different abnormalities with these dogs, and this is just to give you an idea of some of them. The workup for these dogs can be as extensive or not as you as a clinician feels is necessary, and whatever it is you have access to at your facility, of course, and of course what the owner wants to do in regards to diagnostics. Now, for clinical purposes, and actually pathophysiology purposes, you want to think of these conditions as being primary versus secondary. So the primary conditions are those conditions that they were born with. They were already present, and the secondary conditions are going to be the result of the primary conditions. So for example, the most common aspect to that is the stenotic nares. That's where we believe it starts for these younger dogs. They're born with stenotic nares, and that creates an increased resistance to the airway, right? And that increased resistance causes an increase in negative pressure, and it causes downstream effects. It's also not surprising that the nares are the most rostral portion of this disease, right? It's right in front of the face. So if you have an increased resistance in the airway for the nasal cavity, that's going to cause issues with the turbinates, issues with the palate, issues with the trachea, the bronchioles. And so all the downstream effects we think occur from the nose, and then it goes from there. That's the thought, because you can find this as being the most common abnormality in these dogs, and we do see it when they're really young. They're born with it, it's congenital, without having all the other abnormalities yet, if you investigate these dogs further. So think of it as primary versus secondary. It helps when you talk to pet owners. The other way that I also try to define this condition too is based on what's repairable and irreparable. So some of these aspects of this disease you can fix as a surgeon. Other aspects you can't fix, or at least there are attempts to fix them, but nothing that's really standardized. And that helps pet owners understand that you're trying to fix what's fixable, and the stuff you can't, you can't. And that means that you're not expecting to have a 100% normal dog post-op necessarily. You're going to have some residual abnormalities for these dogs, whether it's evident to the pet owner or not, depends on the abnormality, but think of it that way as well. Some are fixable, some are not fixable. So we believe that it starts with stenotic nares, and then from the increase in airway resistance, negative pressure, you'll end up with progressively over time an elongated soft palate. You'll see on a histopath that this palate becomes much more meaty, full of cells, full of fibrosis, scar tissue. It gets longer, thicker, and obviously causes clinical signs that we're all familiar with this condition. Actually, we'll go here. The everted saccules, so right behind the larynx, behind the arytenoid cartilage, you're going to find, if they exist, saccules that are everted. They look like two tiny bubbles back there, and this is fairly dynamic. Over time, I've been addressing these less and less, surgically speaking, because again, saccules I'd consider as a secondary change. Well, I don't consider it. That's what they are. They're a secondary change. And so if you repair, let's say, the stenotic nares and the palate, then hopefully maybe that secondary change, the everted saccules, will dissipate over time. Hopefully. Again, I don't know. It just depends on what the clinical signs are and what your experience is as a surgeon. But everted saccules are part of the syndrome. And then over time, you can have the arytenoids beginning to contact each other. The corniculate and cuneiform processes begin to touch. And as they make contact, as the disease progresses over time and they make contact over time, you end up with laryngeal collapse. And laryngeal collapse causes a deformation of the laryngeal glottis, which of course worsens the clinical signs in these dogs, and that happens over time as the disease is left unaddressed. So just some of the more upper airway abnormalities that you see with these affected dogs. When you look further into these brachycephalics, you'll notice that on CT scan, for example, and just to be clear too, this is not necessarily a routine workup, right? This is in the medical literature, that's why I'm presenting it. I'm not performing CAT scans on these dogs before surgery to screen them for any of this stuff, but I want you to be aware of all the abnormalities when you talk to pet owners about it, whether you're going to perform the surgery yourself or refer it to a surgeon. You understand there's a lot going on with these pets beyond the standard nares, palate, and saccules. So if you were to perform a CT scan of a normal skull dog, you'd see a nice nasal cavity, nasopharynx, and all the turbinates here, all the sinuses, and then in brachycephalic, a lot of that stuff is missing, and it's also smushed in. So they have abnormal turbinates. If you look at them on scoping, you've got a normal, nice open nasal cavity here, and then you have a brachycephalic that's got abnormal turbinates. And so that causes further increase in the resistance in the airway as well as negative pressure downstream. This is just a picture showing the dramatic changes between a more, well, this is not a normal dog either, but differences in brachycephalics. So you've got, like a boxer, pretty good there. Then you've got pugs which have nothing going on in the front. So, which is why we love them so much, but this is the problem. And then when in regards to lower airway abnormalities, the English Bulldog is number 1 on the list for hypoplastic trachea. And so that's a congenital narrowed trachea, and it's diffuse. It's the entire trachea. It's not collapsing trachea. This is hypoplastic. And so they're born with a very small trachea. And that's the English Bulldog. They're the most common, like 70-something% incidence with them. But anyway, you want to have lower airway radiographs for multiple reasons. Number 1 is, do they have hypoplastic trachea? Because that helps you talk to the owners about the condition. It also affects your anesthesia. You're going to want to use a smaller endotracheal tube, right? If you're going to intubate an English Bulldog, for example, that has hypoplastic trachea. You're also looking for metastatic disease, right? So standard screening tool for geriatric dogs, older dogs, which I have cut plenty of very old brachycephalics before. You're looking for secondary bronchopneumonia. You're also looking for non-cardiogenic pulmonary edema, right, which can happen with any severe upper respiratory obstruction. So those are all the reasons to have radiographs, ideally 3-view, but of course 2-view minimum. And And anyway, that's what you're going to do. With the dogs that have chronic upper airway obstruction, it can lead to cardiac conditions, not just the non-cardiogenic pulmonary edema, non-cardiogenic, so not cardiac related, but you can have right-sided heart failure, cor pulmonale with this condition over time. So it can affect the heart as well. And of course that affects your anesthesia, the prognosis, the discussion with the pet owners. So it's very important to try and screen these dogs as best you can, and radiographs are huge. How many folks here, when they've seen brachycephalic airway syndrome in dogs, have also seen a history of gastrointestinal disease, usually chronic, fluctuating? Yeah, yep, a few people, yeah. Yeah, it's very, very common, and it's in the literature as well. It does affect the prognosis for these dogs long term, and whether or not the gastrointestinal disease is part of the syndrome, so secondary, or whether it's a separate issue with that particular dog, who knows, right? But we'll talk about the different types of GI disease, and of course, part of your diagnostic workup, you should have this in the back of your mind. Megaesophagus, for example, has been reported in these dogs as well, and it's not the same megaesophagus that you have from neurologic conditions. This may be more of a secondary esophageal reflux situation, chronic esophagitis, that'll then cause megaesophagus. So that's important, again, for the risk of aspiration pneumonia and bronchopneumonia development. But megaesophagus is one abnormality. This, I think, is probably the most common and probably underdiagnosed because of how annoying it is to diagnose a sliding hiatal hernia. But they probably have that, and it's probably difficult to diagnose because theoretically you'd want to have either fluoroscopy or upper GI scope to diagnose it. Radiographs are only going to catch it some of the time because it's going to be a dynamic process, right? So, but you can imagine with increased airway pressure in the thoracic cavity, the distal esophagus and the stomach are going to be affected by that secondarily, and that's how you're going to get the abnormal movement through the diaphragm. Abnormal gastric motility, not necessarily gastric dilatation and volvulus, right? These are not the breeds that are typically known for GDV, but gastric distension with gas and fluid is also a common secondary situation with these dogs. And then pyloric stenosis is, they're known, this breed, brachycephalic dogs, for getting pyloric stenosis as well. Not very common, but again, it's also hard to diagnose because you have to diagnose that with either abdominal ultrasound or an upper GI scope. So just have this in the back of your mind as well. I do see plenty of brachycephalics that have upper airway syndrome and have secondary GI disease as well. So it's part of your conversation with the pet owner and part of your diagnostic workup. Clinical signs, we all know, they have the loud breathing, snorting, and of course they can be anywhere from just loud dogs, otherwise happy, all the way to laterally recumbent, in shock, cyanotic, hypotensive. So it just depends on how they're going to present to you. Skull radiographs, I don't perform routinely either. The only reason why I mention them here is because you can see on some dogs the palate. You're going to want to diagnose the palate on an oral examination under sedation, of course. But just to show you could see a soft palate on a lateral skull radiograph, as long as it includes part of the larynx as well. This is a radiograph that came from a study that tried to look at how do you objectively figure out if they have hypoplastic trachea or not. Because I tend to just eyeball it, as I'm sure many people do, but you can actually measure it, and in your proceedings has the measurement notes for that. I don't remember the ratio, but they use English bulldogs in that study, of course, because those are the dogs that are poster child for that condition. But anyway, just to show you can objectively measure the tracheal diameter on radiographs. And then looking for bronchopneumonia, like we mentioned. CT scan, we already talked about. This image I'm using just to show that in brachycephalics that are affected with brachycephalic airway syndrome, they can have a deviation to the nasal septum that you won't find in normal muzzled-sized dogs. So that's there. And then, of course, like everything else in veterinary medicine, we try to objectify as much as we can the information we have, right, to make it as less subjective as possible. So you can also grade the abnormal nasal turbinates in these dogs as well if you're performing a CT scan on them. And then laryngoscopy is, of course, a big one because that's where the majority of the fixable abnormalities are going to be. It's going to be the upper airway, except for the nose, of course. And so when you're thinking about laryngoscopy, a couple of points here. Before we talk about laryngeal collapse, if you're looking at the palate, an abnormal palate, meaning an elongated soft palate, typically goes beyond the tip of the epiglottis by between 1 and 3 millimeters. That's typical. You want the palate to end just at the tip of the epiglottis. just at the tip of it. That's where it should end. So beyond the epiglottis, it's abnormal. Now, when you perform the oral exam on these dogs, you're going to have them under sedation, unless they're coming to you comatose, which they can. Otherwise, you're sedating them, sternal recumbency. And remember, when you're manipulating the tongue, if they're intubated, you've got the tube in there, and then you have a small squished face of a brachycephalic, it can be very easy to distort the natural position of that palate. You don't want to falsely make it look better than it actually is, because invariably what ends up happening is as you're pulling the tongue and you've got your laryngoscope in there and the tracheal tube is being pushed to the side, that palate is being stretched in all different kinds of directions and places, and it's going to mess up your ability to figure out whether or not it's elongated. So you want to keep that palate, keep that whole jaw in as much of a natural position as you can while you're trying to figure this out in order to determine is it truly elongated or not. Because again, not every brachycephalic has elongated palates, and you don't want to make the mistake of diagnosing it and then repairing it, and it didn't need to be repaired to begin with. That's going to be a problem. And you also don't want to miss it by thinking it looks normal on your exam. So make sure you're aware of the manipulation of the oral cavity while you're trying to diagnose an elongated soft palate. It's very important. And then the other reason for laryngoscopy, of course, is the laryngeal collapse and everted saccules. So here's a picture of the larynx, and behind it you have those two fleshy bubbling structures. Those are the everted saccules. Here is a picture of an elongated palate. It goes way beyond the tip of the epiglottis. And then this is showing swollen erythematous arytenoid cartilages because they're slamming into each other because of laryngeal collapse. And so deformation of the larynx is a big deal. And the reason why this is a big deal is because it affects prognosis greatly. So we do grade them, stage 1 being just everted saccules, maybe some contact of the arytenoids, but typically the saccules are the main way of diagnosing stage 1. Stage 2, the cuneiform processes of the arytenoids are now touching, and it also includes stage 1 as well. And then stage 3, you've got both aspects of the arytenoid, the corniculate and the cuneiform contacting each other, along with stage 1, of course, and that's where you get the worst. And you'll have even pictures where the arytenoids are like overlapping. It's so badly collapsed. If you have the luxury of scoping the lower airway, or you have an internal medicine specialist that you can refer to or that exists in your building, then you can scope these dogs looking for collapse of the bronchial tree as well, which they will have secondarily. And all the abnormalities we're looking for in these dogs, as we mentioned, the trachea and any pulmonary disease and cardiac disease, that's why you'd have these radiographs collected. But again, the bronchoscopy is the way to look at the bronchioles to see if they are also secondarily collapsing. Now with medical management, obviously oxygen is on our mind when these dogs come in, especially if they're in distress. So this is just a variety of different methods people use to supply oxygen. You know, things like this may not be that practical for these dogs because they're usually also hyperthermic as well, and they're anxious, and so you don't necessarily want to cover up their face, but it's whatever you have access to at your clinic that you can get oxygen exposed to them. Otherwise, intubating them, oxygen cages, and then nasal O2 is typically the way to go for these dogs. But whatever you have access to, whatever the pet can tolerate as well. And then, there's a whole host of medications, right? I mean, your goal with these dogs really with medical management, and this is typically in preparation to stabilize them for surgery, assuming they want to perform surgery on these dogs. You're trying to sedate them and take care of the inflammation from laryngeal collapse. And then, obviously, if they're coming to you in some level of shock, then you're trying to treat that as well. So this is just a generic picture of a bunch of different medications. Antibiotics are an interesting one because if you do perform surgery on these dogs, assuming they don't have pneumonia, it's a dirty surgery, right? The nares and the palates and the saccules. So do you cover them with antibiotics or not? Obviously, if they have pneumonia, you're going to, of course, or if they have any other concurrent conditions, a pyoderma or something, then you're obviously going to treat that as well. But how many people here who perform this surgery do administer antibiotics if they don't have pneumonia? Yeah, like nobody. So if you're going to give these dogs antibiotics, when I have done it, I do like to use either a convenient injection, because it does give you 10 to 14 days of coverage, or cephalodoxime, because at least you get the once a day, for these dogs. Obviously, you want to try and minimize gastrointestinal disease post-op as much as you can, and they may already have a history of GI disease. So the less antibiotics you can give them orally, the better. But that's just what I do. And obviously, if you're treating pneumonia, you're going to go more broad spectrum with pneumonia, right? So, but and then the other aspect that I love of this is metoclopramide, Reglan. So if these dogs come into you not fasted, they may already have food in their stomach before they present it. Now they need emergency surgery in order to stabilize them. So I will give a dose of Reglan pre-op to help with gastric motility, get that food passing through faster, because they're going to be prone to pneumonia anyway post-op. They already are just inherently by being brachycephalics, but of course the anesthesia and stress and all that stuff, they're going to be more prone to GI reflux and then aspiration pneumonia. And then I also will put these dogs sometimes on a Reglan CRI post-op. The CRI is cheaper than the 3 times a day bolusing, and also I think it's efficacious to try and prevent the risk of reflux, regurgitation, and pneumonia with these dogs. That's just what I do for them. I'm a huge fan of using Reglan on them. And then, of course, everybody's been using Cerenia as a pre-med for surgeries in general, and it's great for these dogs too. So standard medical management in preparation for anesthesia is going to be some sort of anti-nausea drug, maybe a GI motility drug like metoclopramide, and then you're trying to sedate them with whatever you have in practice. Typically, we try to avoid hydromorphone because it does cause panting, which you'd want to prevent for these dogs. But usually something, if we're getting ready for surgery, something like propofol bolus, fentanyl bolus, if you want to use a fentanyl to CRI during the procedure, which would be great, and the Cerenia, Reglan, fentanyl bolus, fentanyl CRI, and then induction with propofol, midazolam, and then from there trying to keep them induced with whatever you have access to. Fentanyl CRI is great because you can titrate it to whatever you need for the dog. Otherwise, propofol CRI works too, or gas anesthesia, depending on what you have and what the patient is responding to. And then afterwards, some people will use midazolam to kind of calm the nerves a bit for these dogs, especially if they're waking up anxious. But there's plenty of different anesthetic options for these pets when you get ready for surgery. If you have a really bad situation where you can't even seem to intubate the dog, or it's post-op and there's a lot of laryngeal swelling from either surgical manipulation or they have laryngeal collapse, then you may have to bypass the larynx. And so a temporary tracheostomy tube might be the way to go. This is a pretty straightforward procedure. Any surgical book can tell you how to perform it. Again, it's temporary, so you're not creating a permanent stoma like you would with a permanent trach, but this can help bypass the upper airway for these dogs. And it does add a level of complexity because now you have a patient who's probably going to be on some kind of a CRI post-op, on a mechanical ventilator, or a person ventilating for them, depending on what you have access to. And so you have to now manage this as well. It's got to be changed and flushed, and there's a whole bunch of care for it. So if you're going to dive into this world, just make sure you're ready for it. But otherwise, it is a way that we can bypass the laryngeal cavity. And then surgery for them, of course, you're going to fix what's fixable, right? So the first step here is going to be, for me anyway, is the stenotic nares. So this is before and this is after. Your goal is to open up the nares, but obviously you want it to be cosmetic too, not just functional, ideally. I tell pet owners, I don't know how it's going to heal cosmetically. Every dog is different, of course, because they're going to see the nose all the time, right? So you want to warn them if it doesn't look that great, at least it's functional. But if you can get them to look symmetric and cosmetic, that's cool too. Usually what ends up happening with me is I'll perform the surgery on the dog's right side, and then I do the left side, and then I hate my right side, so I go back and redo it. Almost always. It's the second side always looks better. I don't know why, and so then I just go back and redo the first side. They're going to bleed a lot. I don't have a good way of stopping it other than gauze or Q-tips. If you have sterile Q-tips, again, it's not a sterile procedure, but I still use sterile stuff, so sterile Q-tips. Or if you're lucky to have an assistant in surgery, they can dab for you with Q-tips, and then you can place a suture real quick and another suture. And you only need like 3 sutures really for these dogs, 2 to 4 sutures, and that'll stop the bleeding as you place more sutures. So there's different ways of performing the surgery for these dogs for stenotic nares, but typically what I'm going to do is with usually a 15 blade or an 11 blade. Actually, they work really well, and you just a pizza slice shaped incision. So the base of the triangle will be down here, the pointy part will be up here, and so you're taking a wedge out like this, and then just opposing it with interrupteds. How deep you go depends on the dog. If you have a 14-year-old bulldog with chronic hyperkeratosis, disaster. You know, it's going to be really meaty. If you're doing these on like puppies, then it's going to be just a sliver of tissue. It doesn't take much to open these nares up. After that, you'll then position them for the palate and the saccules. And so this is the standard positioning for these dogs. And again, you're working in a very small space. It's depending on what technique you want to use to resect the palate is up to you. I've gotten spoiled over time. The ligature is fantastic. This thing will it'll cauterize and cut at the same time. And as long as the palate is not too thick, not too meaty, these work great. And they have the smaller ones that I can fit in the oral cavity of a brachycephalic dog. It's phenomenal, absolutely phenomenal. I mean, it takes a surgery that's 20, 30 minutes with lots of sweating and you know, worrying about bleeding, and your suture's holding, and it makes it like 5 minutes. It just zaps right through. Again, assuming the palate is not too thick for it. But this works great. Otherwise, you're performing some sort of sharp excision with suturing for these dogs. And your goal, again, is to try and have it where the palate is just at the tip of the epiglottis. That's your goal. If it's too short, we all know, rhinitis, reflux, aspiration, pneumonia, it's a disaster, and you can't reverse it. So you rather err on the side of it being too long than too short. You can always trim more if you have to. But if it's too short, now you're in trouble. It's hard. You can't fix that. So you can probably manage those dogs successfully with dietary alterations, medications. You know, maybe feed them like a esophagus dog, but otherwise you want to stay a little bit longer if you're not sure. Yes.
You mean when the epiglottis is closed, or is it like at the tip of because it looks like there's a gap there?
Yeah. So this drawing is terrible. Yeah. Yeah. So this is really extreme, but you want it to just be right in front of the epiglottis, right at its tip. Yeah. So there's a picture of it. So you can see they're retracting the epiglottis here, right? But there's the cut portion of the palate there. You can see how it's kind of like frayed here at the edges. And then this is a picture of the saccules. There's a couple ways you can remove these. You can either grasp them with Alice tissue forceps and then medicine bombs to sharp cut them, or you can, if I can fit the ligature back there, I'll just cauterize them off. Yes?
With the ligature technique, is that something that can be done like in the general practice? Or how much swelling do you get? Do they need to be monitored overnight?
So the question is, with the ligature device, how much swelling do they develop post-op? Do they have to be monitored overnight? Can that be done in general practice? So if you can afford the machine and you in your practice you'll use it a lot. I use it for everything: spays, adrenalectomies, splenectomies, whatever. It's got a pedicle, I'm using it. And so I get a lot of use out of them. Yes, you can, if you can buy the machine. And then as far as post-op care, I do way less swelling with the ligature device than I do with the old school, I'm calling it old school, retraction and cutting and suturing. And then for swelling post-op, what's helped me is I've taken a ice cube and I wrap it in some gauze, attach a Alice tissue forceps or hemostat to it, and then I'll place it as we're recovering from anesthesia. The technician is there with the dog, and I'll place it right at the cut site of the palate and leave it for no more than 10 minutes in the gauze wrapped up, and that also helps decrease the swelling as well. There are plenty of times where also we will preemptively treat these dogs with steroids, like either Ciamedrol or Ciadelta or dexamethasone, depending on when you graduated, I guess. And so steroids also perioperatively can help these dogs too with the swelling. But as far as local swelling goes, the ice cube, I like to place it in there, and then of course you have to remember to remove it, obviously, as the dog's recovering. But that's what I'll use. Yeah. Oh yeah. So we'll talk about monitoring a little bit. Yeah. The other thing I was going to mention too. I don't know what the current state of ligature is. I know there was a period of time where they stopped making it or something, or they changed it. So if someone knows anything about that, feel free to speak up. But yes?
How frequently have you actually seen them come back and their soft palate is too short?
So how often have I seen them come back with a palate that's too short? I have yet to see it. Yeah. But again, I'm also biased because I'm a surgeon, and so I work with a bunch of surgeons. So I have not seen it be an issue. You know, you also won't know post-op. Let's say they went home, they're recovering, right? If it was too short, but they're doing great on the first recheck, problem solved. You wouldn't know unless you sedated them again to take a look to see if it is. So, and usually I'm not looking back in the back of the throat post-op after they've gone home unless there's a problem, unless I suspect there's an issue. But I haven't seen it be an issue. These dogs do tend to also, I think maybe some of them, again, I'm biased with it, right? And I don't have like a 2-week post-op confirmation that ours were perfect. It's just whatever the dog is tolerating. If they're doing fine, I'm going to assume it was fine. Yes?
Do you ever use a CO2 laser?
Do you ever use a CO2 laser? I have not. Has anybody here used a CO2 laser for palates? Yeah. And thumbs up, they're great? Or
Not even fun. Ligature's much better.
ligature's better?
No, absolutely.
Yeah. But I have not used CO2 laser. For the nose? Have folks used CO2 laser for the nose? Yeah. Some head nods, yeah. Yes?
Well, since a lot of this seems to stem from the stenotic nares,
Mm-hmm.
we see lots of Frenchies and bulldogs, and you have a lot of breeders. When I see those stenotic nares in that puppy, when should I recommend, we should fix this now, and you can prevent all the secondary issues?
So the question is, since we are assuming that the nares is sort of the start of all this and it's congenital, so you'll see these puppies for vaccines or whatever, and they already have stenotic nares, maybe they already have loud breathing too, even at a young age, when should you start recommending repairing them? And so the easy answer is I don't know, because we don't know, but there's one paper that's in your proceedings, I can't remember who published the paper, where they did a handful of dogs, I think they used a dermal punch biopsy, I think, as puppies, and they reported excellent cosmetics and no complications, and it's great. So I can't remember how young those dogs were though, but it's in your notes. But my point is that we need to do more studies like that. So when you have a study like that, we need more to try and challenge it or confirm that the results were indeed accurate. Because I do think that if we can show that if you repair these at a young enough age, whatever that means, at the time of their spay or their neuter, then that would be a fantastic way to prevent the downstream effects of these, right? Or if you're performing yearly dental on these dogs and you're noticing over time that there's abnormalities happening, right? The palate's becoming more elongated, more thick, then it'd be great to talk to the owners about repairing them now before a dog develops worsening complications, laryngeal collapse, pneumonia, etc. So yeah, I don't know. We need more studies to show how young can you go on these dogs. Yeah. Yeah. And then finally for the irreparable stuff like laryngeal collapse and hypoplastic trachea, these I've seen tracheal stents placed in an attempt to fix hypoplastic trachea. I don't have any literature on that. I'm just throwing ideas out there to you guys. And as far as laryngeal collapse, can you perform an arytenoid lateralization? Can you tie back these dogs? It has been reported, has been done. It's not great. You can also combine that with a partial arytenoidectomy if you really needed to for dogs that have bad laryngeal collapse post-op that are just not recovering well. They have to keep being reintubated. So just keep those things in mind. They're not things that we're routinely recommending for these dogs. It's just options out there. And of course, now monitoring is huge. So when you look at monitoring post-op, it affects whether or not a general practice will even tackle a surgery like this, right? Because if they can go home the same day doing great, then who cares? Wonderful job, they went home, everything's great. But if they have to be hospitalized overnight, you may or may not have that ability at a general practice, and you may or may not have local ERs that are within a reasonable driving distance to transport a pet post-op. And of course, there's cost and stress for the owner and the dog. So, when you look at monitoring, we always use our senses, right? We can look at the gums and we can look at their breathing pattern, listen to their chest. You can do all these things. They're fairly subjective to some degree. We like to have more devices that are objective, and the future of all this stuff, guys, is going to be telediagnostics. I mean, we've already been performing telediagnostics for probably 2 decades, but in its various forms. But now with everything being so high tech in terms of video and cloud storage of data and stuff like that, it's awesome. We're going to see some great things coming down in the next 5 to 10 years for being able to monitor patients from a distance. And so the VetGuardian device from Zomedica is a great way of doing this. And I mean, you're just going to see cooler stuff like this over time. If you're able to monitor a patient from a distance, not only does it eliminate the stress on the staff members for having to try and balance a dog who's crazy anxious, maybe unstable, under sedation, not under sedation, maybe fractious dog, whatever it may be, it helps with staffing. And a device like this also can allow for continuous monitoring without any wires, pads. There's no clutter in their cage. So I'll take a few minutes here to go over this device because this stuff is just awesome. So based on thermography, it can deduce a variety of different vital measurements: body temperature, pulse rate, respiratory rate, without touching the dog, without anything connected to the dog itself. And you get this awesome screen that can be on any device, a phone or a tablet. And you can measure these dogs from anywhere. It's continuous. It's 24/7. It'll give you like text alerts if things are abnormal, depending on what parameters are in the system for dogs and cats. And you can create your own parameters if it's a non-canine feline species. And you can have multiple patients at once that it's measuring. So you've got like, 5 animals here that it's measuring simultaneously, and you can switch to whatever patient you're looking for, and it'll give you these parameters in a patient that's recovering from anesthesia or who's on a CRI of something, because they can't be extubated yet. They can't wake up. Every time they wake up, they go into another vicious cycle. So this stuff like this is the future with monitoring these animals. And so when you look at all the benefits, not just the stat benefits that we mentioned and the benefits to the pet and managing their anxiety, the clients want stuff like this too, right? They don't want if they know their pet is being monitored in a stress-free way, and this stuff this information can be shared with veterinarians without having to physically be there, they want that stuff. It's great. And so of course there's benefits to the practice too, increased revenue for things like having to replace less equipment from standard use of the devices, or people dropping them, spilling stuff on them. It happens all the time, right? How many blood pressure Dopplers you lose and pulse oxes get ruined. But so this type of device can just sit there in front of the cage, either on an IV pole, or you can attach it with this opposable handle on it. You can detach it from the IV pole and attach it to the cage bar, so it's facing right back at the patient, and it's there to monitor. And it's sleek and lightweight, and it's the future for this stuff. You're going to see more of. It's awesome. If there's ways that we can do it to replace more subjective parameters, but also eliminate the staff stress and the stress on the patient, thumbs up for that kind of monitoring. So there it is close up. Here's how it does it. It's just shooting these fancy waves with the dog and then bouncing back at the screen, and then you have these parameters that you can measure here. So, yeah, any device. Is it going to replace all the manual diagnostics? No, of course not. You may still have to perform blood pressures, and it calculates temperature, right? So you may still want to confirm something with a rectal thermometer. There's other ways the diagnostics shouldn't stop at just telediagnostics, but for the right patient, the right scenario, it can mean a lot for you. So I love this kind of stuff, and we're going to see more of it in the future. And then complications of surgery. So, pneumonia, obviously, we talked about ad nauseum now. If you have a tracheostomy tube, there's a bunch of complications associated with that potentially. And then this is a dog that's showing, I was saying before about severe laryngeal collapse, where the arytenoids are like literally just hugging each other. They're so close. These are things that you have to warn owners about post-op. What's the success rate? Well, largely pretty good. Improvement doesn't mean normalization, right? So you can still have a dog that has some clinical signs, they're just better than before. And those clinical signs may be a combination of respiratory and GI. Mortality, 4%. Recovery post-op, so 6 months post-op, excellent, and 65% good, and 25% 1 year, 50% excellent, 48% moderate. And the numbers in the literature all over the place, depending on the study, right? You can have everything from veterinary rechecks, which are a bit more, you can rely on them more, versus client surveys, which may be not as accurate. Whatever. The point is that whatever the pet owners think is going on, that's typically what you're going to go by. And so you can see a pretty good recovery for these dogs. I would say that the salient points for prognosis is get them early. So whatever early means, right? But if they already have signs of progressive respiratory disease at home, then you want to think of this as a differential for brachycephalics, and then hopefully attack it earlier rather than later. Younger dogs, of course, that kind of comes with the early surgery to some degree. But how young, we don't know. Laryngeal collapse affects prognosis negatively. Hypoplastic trachea affects negatively, and so does GI disease. These all worsen the prognosis for dogs. And if you were to repair these dogs early, would that help subside the GI disease? I don't know. Probably, if they're really connected and the GI disease is not related, is not an independent condition, maybe. So key points to make here: client communication is key. Let them know that there's primary and secondary conditions or repairable and irreparable conditions with these dogs. Let them know that the GI disease that they may be reporting or seeing may or may not go away after surgery and affects the prognosis. I have put these dogs on long-term omeprazole as a way to try and see if it'll help some of these dogs that have chronic GI disease. I think it does help, but again, we don't know for sure. It doesn't hurt, but we don't know for sure. And then, of course, you're going to tailor the surgery to the patient, right? It depends. I mean, if they don't have an elongated palate, you don't touch the palate, So you're trying to figure out what conditions can you diagnose in your practice, and then which one of those conditions are repairable or not. Yeah, and I'll just, again, thank you guys for attending, and thanks to Fetch dvm360 and Zomedica for sponsoring the talk. And any questions you have, I'm happy to take. Yes?
So, after 15 years in an ER doing those older dogs, now I'm in the general practice doing smaller puppies. And most of our dogs we see come in with slit noses, we're just recommending doing them this way. However, you go in and you're looking at the soft palate. And some of those dogs are kind of questionable.
Mm-hmm.
They look a little long, maybe a little thick, but what are your thoughts on leaving those alone and kind of seeing what happens versus going in and do all that at once?
So the question is, if you're performing the nares surgery at a young dog during a spay or a neuter, and you notice that the palate is maybe questionably long, do you touch the palate or not? So over my years of doing this too, I've become more and more conservative when it comes to things like this. I would leave the palate alone. That would be my opinion on it. I don't know what the answer is, but that's my opinion on it. Because again, in theory, if the nares are the primary starting point of all this, less is more sometimes, and so it would be beneficial, especially if it's a situation where it's an unfortunate situation where you perform the procedure that was sort of questionable, and now you have all these complications post-op, and you just wish you left it alone. Versus you can trim it later if it's causing a problem later, if it's getting worse over time. And a lot of these dogs are going to come back to you hopefully for routine dentals, right? And they'll be under anesthesia for that. And so you could theoretically every year in the dog that's questionable in terms of the palate length, you could just evaluate every year or two whenever the dental happens for that patient and look at the palate and see whether or not it's progressing over time and have that conversation with the owner later on. So my preference would be to leave it alone. Same thing with the saccules. I used to remove all the saccules as long as they were everted. And then over time, I started noticing that if I just watch the saccules after I've done the nose, I did the palate, while they're still under anesthesia, and I'm watching the saccules, they kind of slowly deflate as I just watch them. And then I've been leaving them in, and I haven't had a problem yet with leaving those in. So I'm becoming a bit more conservative when it comes to these. So that would be my answer. I would leave it alone if it's questionable. You can always repair it later on if you have to. Especially an owner who's proactive. If they're like, yeah, I want to do it, let's do the nose now, then they're probably going to say yes to a palate later if you say it needs to be done. So,
Thank you.
yes.
I've been seeing a lot more brachycephalic, as I feel everybody has, and I've had a couple owners that come to me just for their wellness, and they'll show me a video of their dog that is doing nothing, it either regurgitates or vomits and then passes out. We're not sure if it's a vagal event, a seizure, or what is happening. But have you seen any that are like that and surgery fixes them and they quit doing those events, or is that just isolated, they've probably got other things wrong?
So the question is, in brachycephalics, they're showing more vagal signs at home, so syncope, acute syncope. Do you see, in those cases, do you see if you repair their airway syndrome that maybe that resolves it, or is it not related, or is it related? What's the deal there? So a vagal syndrome, vagal collapse in dogs, clinically, of course, is very difficult to find out because it may happen at home and no one ever knows the difference. And I'm convinced, I never saw any in my career, and then once I started vet triage, these people will call up, they describe what sounds like a perfect syncopal episode, dog's never had it, it's fine now, and I talk about that now, whereas I never talked about it before. If it's syncope, I'm looking for, okay, is it truly syncopal or is it neurologic? We're looking at the heart or the brain, right? And now I have this conversation like at least once a month, which, that's not nothing. So these dogs, Brachycephalics, are also known to have a higher vagal tone than other breeds as well. And anytime you mess with a dog or person, their eyes, their GI tract or respiratory, you're stimulating the vagus nerve, and then you could have a syncopal episode. That's the pathophys. Obviously a huge generalization. And so anyway, will it fix these dogs? Maybe, because we don't know right? But the pathophys of syncopal collapse, if it's related to a overstimulation of the vagus nerve, theoretically, if you fix this, maybe it'll help those dogs out. It is important to always dive into, and we all know this, but dive into the patient's history, right? Really quiz the owners on the whereabouts of this episode. Was the dog acting weird before it happened? Was there any sort of environmental factor that may have played a role? Was there thunderstorms or motorcycles or ambulance sounds or whatever? How long did the episode last? Did they see the salivating, urinating, defecating during it? Was it a very calm event, or was it convulsing and tremors, intense muscle activity? How long did it last? How long before they became normal when they woke up? And if they were abnormal at all after it happened? And then was it the only time they've ever seen it, and all that? So careful investigation. Maybe you can differentiate between actual neurologic disease versus cardiovascular, which are going to be the main two things. But yeah, it's fun in terms of thinking about it and investigating it. But you have a pet owner who wants an answer and a solution, and the workup for both these things are expensive and require, a cardiac workup and a neurologic workup require some fancy equipment, maybe some specialists involved, and so and all for the chance that everything could come back normal. And you tell the owner, we did everything. I don't know. We're $6,000 deep now, and I don't have the answer. Maybe now it's vagal, and that's it. They're like, really? That's the answer? But unfortunately, it may be. You warn them ahead of time that you may have to do all these fancy tests and find out that everything's fine, and this is a vagal event. So I don't know the answer to that, but I suspect it's going to. There's some role it plays. I just don't know. Yeah. That's why you want to be careful during surgery, by the way. And if you're performing like an enucleation, for example, on a dog, obviously you don't want to retract the optic nerve too aggressively because you can cause contralateral blindness. But the collapsing thing, the sudden drop in blood pressure, is a problem if you're manipulating the eye. I mean, I think any ophthalmologist would tell you about that, the reflex. What is it, vasovagal reflex or whatever it is. I'm not smart enough for this, but you gotta be careful in surgery when you're manipulating organs that are related to the vagus nerve for that reason. Anyway, just a side note. Any other questions? Okay, thank you very much. Thank you.